Thank you all for joining us today. I am Meg Mangan, Waldenstroms patient and IWMF trustee. I'm very excited about today's topic because it's an important issue for people with Waldenstroms, especially in this time of COVID-19. It's my pleasure to introduce our presenter, Dr. Andrew Branagan. Dr. Branagan has deep-rooted experience with Waldenstroms since serving as the inaugural Waldenstroms program manager at the Dana-Farber Cancer Institute. He was most recently recruited to Massachusetts General Hospital Cancer Center in Boston to focus his clinical research on multiple myeloma and Waldenstroms. Dr. Branagan is well suited to tell us about today's topic, infection prevention strategies. And at the conclusion of his lecture, there will be a question and answer session. Now over to you, Dr. Branagan.
Thank you so much, Meg, for that introduction and for the opportunity to speak to you all today. I'm Andrew Branagan from the Massachusetts General Cancer Center. And what I want to cover today are infection prevention strategies for Waldenstroms macroglobulinemia. And I do think this is an under-researched topic and a very important one. So here's the agenda of what I'd like to cover. One, an overview of the immunosuppression associated with Waldenstroms macroglobulinemia. Second, to review infections which are encountered in patients. Three, review infection prophylaxis strategies, followed by summarize some recent research studies and evidence supporting a novel influenza vaccination strategy for Waldenstroms. And finally, to highlight ongoing research efforts designed to study and improve immune responses to COVID-19 vaccination. So plasma cell dyscrasias, which include multiple myeloma and Waldenstroms, are associated with diminished immune responses to infection and vaccination. And in fact, this is one of the hallmarks of these diseases. So most pronouncedly, there is a B-cell dysfunction. And this is clearly seen with decreased normal levels of antibodies, also known as hypogammaglobulinemia. Additionally, there are some disruptions in the T cells. And you can see here some examples of this. So T cells themselves and also some of the other supporting immune cells. Next, there's age-related immune senescence, which means as we get older, the immune system weakens, and Waldenstroms is associated with older age, so these can happen in parallel. And then finally, the anti-cancer Waldenstroms therapies we use, such as cytotoxic chemo, corticosteroids, monoclonal antibodies, and BTK inhibitors may further diminish immune responses in different ways. And I will discuss this in a few minutes. Additionally, MGUS, the precursor state to Waldenstroms, myeloma and Waldenstroms itself, are associated with depressed protective antibodies to several infections. And so this has been showed by several groups. And the specific antibodies that have been low when looked in these patients are staphylococcal toxin, Moraxella, pneumococci, tetanus, varicella, candida, and aspergillus. And then we see that antibody depression significantly worsens on disease progression in Waldenstroms. And also, if you have low total normal IgG antibodies, this increases the risk for, especially for encapsulated bacteria, and those include pneumococci and Haemophilus influenza. And so here's some actual examples of this. So this study looked at patients who had myeloma, Waldenstroms, MGUS, or healthy controls. And you can see here in the graphs, the second one in is Waldenstroms, and the far to the right are controls. So if you look where the controls are, you see with Waldenstroms that these protective titers are lower. And this is consistently seen for all the examples here with anti-staphylococcal IgG, anti-pneumococcal IgG, anti-tetanus and diphtheria IgG, and anti-varicella IgG. Another interesting thing to note is, though, MGUS is a lot closer to the controls, but for certain infectious antibodies, there's actually a decrease even in the precursor MGUS state, although not as pronounced as with Waldenstroms or myeloma. And so I want to come back to changes that can happen from the therapy for Waldenstroms. So first, corticosteroids. So steroids are generally part of most regimens for Waldenstroms. And these can cause suppression of cell-mediated immunity, and they can increase the risk, for example, of zoster, CMV, or PJP, a type of rare fungal pneumonia. Proteasome inhibitors, examples of these would be bortezomib or Velcade, carfilzomib or ixazomib. They may increase the risk of zoster reactivation. So in this case, it is very important that patients take antiviral prophylaxis when on those medications. Third, there's cytotoxic chemotherapy. So these include several classes such as nucleoside analogs. Fludarabine would be an example of that. Alkylators, and so bendamustine would be an example of that. And these can be associated with neutropenia and the disruption of mucosal barriers, which can put people at risks of infections. Next, BTK inhibitors, so ibrutinib or zanubrutinib, for example, are associated with neutrophil dysfunction, and they may increase the risk of pneumonia. So in many of the trials, there was an increased risk for getting pneumonias. So that's something to keep in mind. And then finally, CD20 monoclonal antibodies, so rituximab being the most common one of these, may deplete normal B cells. So as I mentioned, we already have most of the time some reduction in normal IgGs, so this can further reduce that, increasing risks of certain infections. And so you can think of some of these risks that I mentioned as a way to stratify a patient with Waldenstroms as being at low risk for infections or intermediate risk, or even up to a high risk. And so, for example, with age, if someone is young, that's a lower risk factor, as opposed to older, that would be a higher risk factor. And then having any of these factors here would increase the risk of infections. So for example, frailty, having other medical conditions, not having a spleen. And in terms of Waldenstroms itself, if there was a lot of disease, that's called a high tumor burden, or if the Waldenstroms is very active and either relapse refractory or progressive, that puts someone at a higher risk of infection. You can also think in terms of how many lines of therapy. The greater the lines of therapy, the bigger the risk. And also neutropenia, for example. So having a neutrophil count less than 100. And having, if you had an autologous stem cell transplant, that would be a higher risk for infections, especially within a 1 to 2 year period. And this is a treatment sometimes used for Waldenstroms. And to put this to numbers, there was an excellent study in Sweden, which is known for doing large population studies, and they looked at infections in Waldenstroms patients. So they looked at 2.6 thousand Waldenstroms patients and compared them to 10,000 healthy controls. And sure enough, there was a 3.2-fold increased risk of getting any infection if you had Waldenstroms compared to being a healthy control. And if you considered specifically viral infections, there was a 6-fold increased risk of viral infections. So you can see here some of the more common infections they found. So with bacteria, that includes septicemia, endocarditis, pneumonia, meningitis, cellulitis, osteomyelitis, and pyelonephritis. And in terms of viral infections, the most common were herpes zoster and influenza. So here is a summary of recommended vaccines for patients with Waldenstroms. And the title you'll see doesn't say recommendations for Waldenstroms because that really doesn't yet exist. So there's no consensus that gave exact recommendations for Waldenstroms. So really it follows the guidelines for other plasma cell disorders. So that's something I'm hoping we can change soon and get together a consensus panel to give some more specifics for Waldenstroms. But for now, you can see here, the 3 most important are the first 3. So influenza, pneumococci, and herpes zoster. So these are the most important to consider. And then there are some other vaccines. So let's start off with pneumococci in general, especially in the US, where these are available. The recommendation is to receive a conjugated PCV13, and that's followed by a Pneumovax or PPSV23. And this is supported by the National Comprehensive Cancer Network and the International Myeloma Working Group. And in terms of zoster, same bodies support that everybody with a plasma cell disorder should get vaccinated with Shingrix. And this is a 2-dose series. Some places in the world, Shingrix is not available, but in general, we like to avoid live vaccines. So Zostavax is avoided in Waldenstroms. So then in terms of influenza, this may be the most provocative that I say on the list, because there is no, this is not widely adopted yet, but there is a recent recommendation from the IWMG, again, International Myeloma Working Group, which I'm a part of, that all patients should get 2 high-dose flu vaccines. And I'll explain why that is and the research behind it in a few minutes. But first, let me just zoom in on the 3 most important vaccines that I mentioned. And the first one being streptococci vaccines. So you'll notice that you want to vaccinate as early as possible, ideally before you start an anti-Waldenstroms therapy. If you had no prior vaccination, the preferred order is to give the PCV13 first, because that's more immune stimulating, then the PPSV23 later. Then you'll notice for influenza, as I mentioned, that's my recommendation, and that's what we've adopted at Mass General Hospital for all patients with plasma cell disorders, including Waldenstroms, is all patients get 2 high-dose flu vaccines. The first one should be annually before the onset of flu activity, so as soon as you can get it. So that's actually right now at the time this is being recorded in September. And then the second dose separated by at least 30 days. And again, this is the high dose vaccine that's in general only available to people over the age of 65. But if you had Waldenstroms, this would be a recommendation for any age. And then finally, for zoster, the recommendation, it's a definite if you've had a stem cell transplant, but really the IWMG and many providers recommend all patients with Waldenstroms should get the 2 doses of Shingrix. And the first one is given, and then the second one 1 to 2 months later. And so what about taking antimicrobials to prevent infection? So antimicrobial prophylaxis in Waldenstroms. So some examples here include first considering viral infections. If you have a really low risk of a viral infection, generally nothing's done. But if it's an intermediate or more risk, and one example of that, as I mentioned before, is if you're getting a proteasome inhibitor therapy, then we consider suppressive therapy for a time being with acyclovir or an equivalent drug. Sometimes also if somebody is positive for hepatitis B, they may go on prophylaxis to prevent that from being reactivated before getting certain therapies. Then in terms of fungal infection, sometimes this is another case where we consider putting someone on antifungal treatment to prevent infections if somebody is really severely neutropenic, so having a very low neutrophil count. Secondly, if somebody is really at a high risk and has prolonged neutropenia, we may consider prophylaxis against the PJP pneumonia, the rare fungal pneumonia I mentioned, and that is generally with Bactrim. And so now I want to turn your attention to the flu. And I mentioned before the research I wanted to share with you on why 2 doses of flu vaccine. So here's a picture of a flu virus. You'll notice some key proteins, HA and NA. And these together, these different surface proteins make up the seasonal strains that we see every year that are common and that we vaccinate against. And so worldwide, every year, the flu is a source of morbidity and mortality. People get sick and people die around the world. We do know that older adults, especially those who have comorbidities like cancer, are more susceptible. In fact, 90% of flu-related deaths are in patients who are over the age of 65. And in 2005, the American Cancer Society looked at all cancer patients admitted to the hospital with the flu and a very high number died, which was 9% of all cancer patients. So in the US, we have available a high-dose flu vaccine, and this is approved for adults over the age of 65, because as I mentioned before, the immune system can weaken with age, and this was shown to prevent more flu in that population. What we did know about Waldenstroms and myeloma and other plasma cell disorders is that with a standard regular dose flu vaccine and just a single dose, protection with titers was very poor. At most 20%, and most studies were closer to 5% of patients had protection only. And so what I wanted to do was try to figure a way to improve on that. This is a pilot trial called Shivering. It was the study of high-dose influenza vaccine efficacy by repeated dosing in gammopathy patients. And this was trialed in a mix of myeloma and Waldenstroms patients. And sure enough, there was no trouble or increased side effects with getting 2 high-dose vaccines. And the protective rates with titers against the flu were seen in 65% of patients, so much higher than the historical studies. So with that in mind, we embarked on a randomized trial called the Shivering 2 trial, where we compared patients with Waldenstroms and myeloma getting 2 high-dose flu vaccines, so they were separated by 30 days, versus the standard of care, which was 1 age-based vaccine. So just as you would get in regular clinical care. If you were over the age of 65, 1 high dose. If you were less than the age of 65, 1 standard dose. And a placebo was given, so no one knew which arm of the study they were on. And sure enough, you can see here after the first dose, everything was the same because this is just 1 dose that's equivalent. But after the second dose or after the saline placebo, those who got the second vaccine had higher rates of protection after just 30 days after the second dose. Then when we followed patients throughout the flu season, we saw that at day 60, there was an increased protection. But very interestingly, at the end of the flu season, what dropped rapidly was those patients who just had 1 vaccine, only 1/3 of them still had protection against the flu. But if they had the second dose, almost double as much had protection at the end of the flu season. And you may ask, well, that's all plasma cell disorders. What about Waldenstroms? So sure enough, the same trend held true for Waldenstroms. This was presented at the International Waldenstroms Workshop number 10 in New York City. And you can see here the same thing, higher protective rates after the second dose, and at the end of the flu season, higher protective rates for patients with Waldenstroms. We also looked at what factors were associated with getting protective antibody titers against the flu versus not. And you can see here, if you were a female, you had a higher chance of getting protection. This is consistent with some other vaccine literature. If you were older, there was less of a chance to have protection. And then if you had asymptomatic disease, you were much more likely to have protection. If you were in a remission, so as opposed to having progressive disease, much more likely to have protection. If you had less numbers of prior therapy, or I should say at the reverse, if you had more numbers of prior therapy, you were less likely to get protection. If you had the flu the year before, there was some carryover immunity and you were actually more likely to have some protection. And if you received IVIG, you were more likely to get protection from some passive transfer of antibodies. If, however, you were on cytotoxic chemo, such as an alkylator therapy, you are less likely to have protective antibodies. So these are just the summaries of what I just said. And because of that, we recommend this to our patients at Mass General, and the International Myeloma Working Group has adopted this as a consensus recommendation. So now let's turn our attention to COVID-19, which is on everybody's mind. And so this is a single-stranded RNA virus. This is what the picture looks like. These are all the available vaccines, either currently in use or under development. And you can see here on the left, the mRNA vaccines include Pfizer and Moderna. You see here the viral vector vaccines include the J&J vaccine we have in the US and the AstraZeneca available in other parts of the world. And so approved and emergency use authorization COVID-19 vaccines are designed to elicit SARS-CoV-2, that's the virus behind COVID-19, spike protein antibodies in healthy individuals. So that's the goal, and that's what they're designed to do. There are no established titers of what is clinical protection. The specific immune responses and degree of protection are largely unknown for cancer patients, plasma cell dyscrasia patients, and Waldenstroms patients. So that's why we undertook this study several months ago. And this is a summary of the study. It was a prospective trial, so we wanted to catch people before they had their vaccines. The name of the study is the Study of COVID-19 Vaccine Responsiveness in Patients with Multiple Myeloma and Waldenstroms Macroglobulinemia. It's open at Massachusetts General Hospital and Dana-Farber Cancer Institute. At Dana-Farber, Dr. Sorosiak is leading up the Waldenstroms effort there. And this is a picture of the schema of the protocol. And so it's open for myeloma patients you see on the top, Waldenstroms patients on the bottom. The Waldenstroms patients are stratified by the treatment they're on, and I'll say more about that in a moment. And then they receive whatever vaccine they were to receive clinically. And we checked their response to that vaccine. We checked after the first one. If it was a 2-dose series, we checked after the second one. And then there were subsequent tests throughout the period of a year. So this is still ongoing. Many people are now at the 6-month mark, but we're going to collect also blood work at 9 and 12 months to see how durable any immune responses may be. So the primary objective is to measure the anti-spike antibodies after that complete vaccination, which is, again, either 2 mRNAs or 1 J&J vaccine. What we're also looking at, and will take a little more time, are the durability of immune responses, clinical correlates of immune responses, the rates of COVID-19 infections with surveillance, and then finally functional antibody tests and tests to look at T cells and other cell-mediated changes, which I'll share also in a few minutes. And so we first looked at the main spike antibodies with a test that many of you may be aware of, because I know this is a widely used test by Roche called the Alexis assay. And this has a range of 0.8 to 2,500. And when healthy individuals have their series of vaccinations, generally their spike antibodies are in the thousands. So there is no established cutoff, but that's something to keep in mind. Here's an example of a study that looked at nursing home residents. And as in with many studies, the controls were over 2,000 with their average titer. But even the nursing home residents who were older in age, had other illnesses, they actually still had an average of over 1,000. And so that's what we'll keep in mind. What you need to neutralize the virus is somewhere between 100 to 500 of a titer. But again, no established cutoff. Some studies use some range in between there for what is defined as adequate protection. But another thing to keep in mind is as we have more strains and variants, this number may not translate into neutralization quite the same way as the original virus. And so here's a snapshot of our study. And again, this is the first check right after vaccination. And you can see here, titers are low right off the bat. For myeloma, the average or median titer, which is the right in the middle of half or below that, half or above it, is only 178. And you can also see right off the bat, for Waldenstroms, these titers were even lower as a whole. And the median titer was only 3.62. These are the baseline characteristics. At the point that this abstract I was just presented in Vienna at the International Myeloma Workshop. And at the time of this abstract submission, there were 137 patients. 3 were censored because they had infections before going on the study. And so the rest of what I'll show you is a summary of 134 patients, 89 of which had myeloma and 45 had Waldenstroms. And you can see here their clinical characteristics. And when we look at what percentage had spike antibodies that were detectable, with myeloma, actually 91% had a detectable just at the lower range of the assay. And with Waldenstroms, only 46%. When we looked at what we defined as adequate, and this cutoff we used as 250, only 57% of patients with myeloma met that cutoff. And unfortunately, with Waldenstroms, only 24% met that cutoff of having a titer over 250. And so I'll show you some more slides which show some of the factors that may have made a difference with having or not having protective titers. So you can see here, patients aged 75 years or older were less likely to have adequate titers, so 13% as opposed to 42%. Which vaccine you received also seemed to matter. So patients who received the Moderna vaccine overall, higher percentage had adequate protective titers, 61%. This was followed by those who received Pfizer, 28%, and this was followed by those who received the J&J vaccine at 15%. Now, turning to Waldenstroms, I mentioned we stratified by treatment, and one of the main reasons was the therapies are so different nowadays with this class of BTK inhibitors. We wanted to be sure we had enough patients receiving BTK inhibitors to see if there was an effect there. And also, we wanted to know if you didn't yet have a treatment, what things looked like with Waldenstroms. So the cohorts are 2A. This is treatment naive patients, so patients who never had a therapy yet but have Waldenstroms. So they actually, most of them did have protective adequate titers, 64%. 2B were patients who were actively taking a BTK inhibitor. And unfortunately, only 10% of those patients had adequate antibody responses. And third were patients who either currently or previously had other therapies besides a BTK inhibitor. And again, unfortunately, only 14% had protective adequate titers. When we zoom in on the other types of therapies and consider just rituximab, you see here that those patients who had rituximab within 6 months, none of them on our study were able to have adequate protective titers, as opposed to 31% if they did not have rituximab. And then if you look at absolute lymphocyte count, this made a big difference for myeloma, where if you had a low lymphocyte count starting off, you were half as likely to have protection. This was just a trend, but we did see the similar trend in Waldenstroms, where only 9% had protection if they had low lymphocyte count, as opposed to 27%. And then we looked at response status. This made a big difference with myeloma, where those who were progressing had lower titers, but for Waldenstroms, we didn't see a difference. And that may have to do with the rates were so low to begin with, and there weren't enough patients to do too many subgroup analyses, we say, and break that up into different ways. But what was very clear were, if you look at the far right, patients who had asymptomatic Waldenstroms, so the precursor state, never been treated, not having any symptoms, a little bit different than the last slide I saw you with, had never received a treatment, because that included patients who were about to start a treatment, who actually had some progressive disease, but just didn't yet have a treatment yet. These are the truly asymptomatic patients, and sure enough, 100% of them had protective titers. And this is very different than what we see in a disease like CLL, where even if you don't have your treatment yet with CLL, and you're asymptomatic, we see profound differences in responding to COVID vaccines. So just to summarize these preliminary COVID results, they suggest that spike antibody responses are poor in patients with myeloma and Waldenstroms. Waldenstroms patients showed more severe impairment of spike antibody production. Moderna elicited the highest spike antibody response rates. Age over the age of 75 years was associated with lower rates of spike antibody responses. Asymptomatic and most of the previously untreated Waldenstroms patients did achieve adequate spike antibody responses. The most significant reduction in spike antibodies were seen in patients either actively treated with BTK inhibitors or having had Rituxan within 6 months. So ongoing, we have our durability spike antibody response studies, also comprehensive functional antibody responses, because whether or not the antibodies are there, what no one's really showed yet is how well do they work. And so we have, we'll hopefully be presenting some of that at the American Society of Hematology meeting in December. And also we have ongoing studies on T-cell responses. And what I think is very important, COVID-19 strain-specific responses, because some of these tests are done in a laboratory against the original strain, but we have mutating viruses. And so just to show you a little bit about how the vaccine works, whatever the antigen or protein from the virus or protein mimicking a virus is, it's taken up by the body. And CD4 T cells are crucial in making that immune response and communicating to the cells that bring the proteins and to those B cells that ultimately will make antibodies. The other thing these critical T cells do is they help the T cells called cytotoxic T cells that actually fight off and kill COVID. So what we're going to do is look at the different classes of T cells and see how they may be different in patients with Waldenstroms. We're also going to use a cutting-edge system serology platform that will tell us a lot about the antibodies themselves, all the different parts of the COVID that they can bind to, how well they bind, how well they activate and pull in other immune cells. And so, for example, these are some of the types of antibody functions that we're looking at. And we're going to look at the different strains, as I said, as you can see on the top. So just a couple updates before I wrap up today. These are some fresh updates. One is, as you all have probably heard, there was an FDA release that followed by an NCCN recommendation that all patients with hematologic malignancies can receive a third dose, regardless of whether they are receiving cancer therapy. So in the US, if you have Waldenstroms, you are eligible to get a third dose if you were originally vaccinated with an mRNA vaccine. And this is based mostly, though, on a solid organ transplant patients. And so it may not be one size fits all, but for the time being, 3 is probably better than 2. And we're going to also look in our study how this may improve the antibody responses, which I shared to you. Another update, I just want to kind of show you how quickly this virus is mutating. And you can see here that there's 2 mutations a month. This is about half as fast as the flu and about a quarter of the rate of HIV. And what this means is this is a nice study that was done in Spain. And Spain did a good job of really subtyping their infections and knowing which strain people were getting infected with. That's why I think it's a good example. And you can see here back, if you look early on, October, November, it was other strains. The alpha strain started to take over early in 2021. And now it's really the Delta that's taking over. And now it's almost all Delta variant in the current infections. And I want to share one final slide. This was also from the International Myeloma Workshop we just returned from in Vienna. And this is a study from Mount Sinai where they looked at a myeloma patient. So this was not Waldenstroms, but I still think it's quite interesting. These are T-cell responses in patients who did not have any antibody response. So you'll see here, that's what the red is. And so in the red is these patients, like I showed you before, we can't detect any antibody response. They still had some CD4 T cell responses that in the laboratory could fight off COVID-19. So I think that's somewhat reassuring. It proves that there's still some partial protection, even if you do not see an antibody response. These T cell responses were less than those myeloma patients who did have antibody responses. And interestingly, if you did have an antibody response, the T cell functions were pretty similar to the healthy control, which are the next group of dots, which are the blue dots. So with that, I just have a few conclusions here. I want to remind everyone that Waldenstroms is associated with a relative immunodeficiency. This is evidenced by an increased risk of infections and impaired responses to vaccinations. All Waldenstroms patients should be aware of infectious risks and discuss individual recommendations with their providers. The following vaccines are recommended: pneumococcal vaccinations, Shingrix zoster vaccination, 2 high-dose flu vaccines each season, and COVID-19 vaccination. Antimicrobial prophylaxis may be recommended based on individual history and recent Waldenstroms therapy. Immunoglobulin replacement may be beneficial in certain individuals with Waldenstroms. Currently, Waldenstroms patients are eligible for a 3rd dose of mRNA vaccines, Pfizer or Moderna, under the recommendation I mentioned. Our COVID-19 vaccine study and others are ongoing to determine the optimal vaccination strategies, such as specific vaccines, boosters, or alternative strategies that may be beneficial. And finally, additional research I feel is clearly needed to better understand the specific immune defects associated with Waldenstroms and also associated with the Waldenstroms directed therapies, so we can minimize the risk of infections in patients with Waldenstroms. And so on behalf of all the many people who've helped with the studies that I shared with you, both at Mass General, at the Dana-Farber, Branagan Institute, and also some of these studies were conducted at Yale Cancer Center with the support of an award from American Society of Hematology. And I thank the IWMF for this opportunity to share this, this data with you all and for all you do. Thank you very much.
That was a fabulous talk, Dr. Branagan. We really appreciate your sharing such clear and helpful information about preventing infections. Now, in the time remaining, Dr. Branagan will answer some of your pre-submitted questions. Question number 1 is, how do I know if I am immunocompromised? What blood lab numbers are taken into account to determine if a person is immunocompromised?
Well, thank you for that question. As I mentioned in the talk, I would argue that all patients with Waldenstroms have some degree of immunosuppression. And based on many of the factors I discussed, that can be more or less. So one of the major factors is the degree of suppression of normal antibodies. So generally, that's IgG. And when the level starts dropping below 500 or 400, that starts to increase the risk for infection. Also, white cells are important, particularly neutrophils. And when the neutrophils start dropping below 1,000, that starts increasing, further increasing the risk for infection.
Thank you, Dr. Branagan. Next question. Does a person's level of IgG correlate with the amount of spike antibodies produced by a COVID-19 vaccine? And is this being assessed in vaccine response studies?
Yes, again, a great question. And yes, we're looking at the level of IgG and how that correlates as one of the clinical correlates. We did not see a relationship in our studies so far. Some others have. So there probably is some relationship. I think one of the complicating factors is that patients with low IgG sometimes get IVIG replacement. At our institution, we're very generous with IVIG because we believe in it and we believe it prevents infections. And we are now seeing protective antibodies in the IVIG. And so that, I think, is interfering with the analysis. And it's one thing we are looking at, different ways to analyze this once we have the rest of the data for the remainder of the year.
Thank you, Dr. Branagan. When should I be concerned about low white blood cells or low neutrophils? What levels are considered low?
Yeah, this is very, very correctly narrowed down to the neutrophils, because of all the white cells in the blood, this is the most critical one that really increases the risk of infection, as I mentioned. So anything that starts to drop below 1,000 starts to increase the risk. This significant risk really happens less than 500, and that is, if anything can be done to increase that, generally that's when medications are given and additional precautions. But really, when it starts to go down below 1,000, that's when you want to start to watch that and ask your doctor about it. That's how I would think about it.
Thank you. Do WMers on watch and wait need to be concerned about immunosuppression?
Yeah, this is a question I have and when I embarked on some of the studies I shared with you. And again, I like to think of immunosuppression as a spectrum. And there is some mild changes in the immune system, even from the precursor MGUS states, but they tend to be subtle. And I think the COVID-19 vaccine data I shared with you is evidence that most watch and wait WMers actually have a very intact immune system. And really, it's when Waldenstroms acts up and progresses that really takes a big hit on the immune system. So I would say it's always healthy to have some concern, but far less concern than somebody who is progressing or on an active therapy.
Thank you. Are some WM treatments more likely than others to increase the risk of infection?
Yes, most definitely. And I like this question because it helps me point something out, which is, when I started studying Waldenstroms and working at Dana-Farber in the year 2001, there was little known about the disease, and a lot of people were using very toxic chemotherapies. And very often we would see worse outcomes from the treatments than from the disease itself. So I think that's the beauty of the consensus recommendations we have now and the trials that have shown recommended therapies. So in general, all the current recommended therapies are much safer than the older therapies, which were more immunosuppressive. But as I mentioned, there is still some immunosuppression, and it's different what type of immunosuppression based on which therapy you receive.
Thank you. This next question ties in with that. What are the effects on the immune system of bendamustine rituximab treatment, and how about the effects of ibrutinib?
Yes, so and I covered some of this in the talk. Bendamustine is an alkylator chemo, and one of the main side effects is neutropenia. In fact, we almost are certain that the neutrophils will fall, and so most of the time, if not all of the time, patients are given a booster for their white cells when they're on that medication. Ibrutinib, again, it has some changes to the neutrophils, but usually we don't see neutropenia as much, but you do see an increased risk in pneumonias on ibrutinib. A small increased risk, but it is consistent across studies.
Thank you. When is it appropriate to order Ivig infusions?
Oh, I love this question, and it's very controversial. So as I mentioned, I really believe in IVIG. I think we use it quite a bit at Mass General. I tend to use it all the time when someone drops below 400. And then also depending on the patient's individual infectious history. If somebody continues to get infections, it really doesn't matter what the IgG level is. Usually that should be tried, and often that helps. So some people are more susceptible to infections, even with just small changes in their IgG. But I think for sure less than 400, and for sure less than 200 when when the risk of infections would go up even higher. But you'll find that this is very different around the country and around the world, and not everyone is as aggressive. But I think the agreed recommendation is if you have a low IgG and you've had 2 or more serious infections, then it is time for sure to be put on IVIG.
Okay, thank you. This person said, I have had many IVIGs and I'm on Imbruvica. I have had many infections, both fungal and bacterial. Is there any other method for us besides IVIGs to combat infections?
Oh, wow. No, I'm sorry to hear about these complications. And again, I can't give specific medical advice, and it's hard not knowing all the details here. But one thought is, how is the IVIG being used? Sometimes we can increase the dose if the dose is not enough. Sometimes increase the frequency. So generally, once a month is the maximum you can do it. And then also, I'd wonder what the neutrophil count is, if anything can be done to improve that, and what exactly where these infections are, and if there's anything else that can be done. But usually the first step is really to make sure you're maximizing the IVIG.
Thank you. The LLS COVID-19 vaccine antibody study announced that 26% of 74 Waldenstroms patients tested seronegative to the vaccines. Do you have any insight as to what our T-cell response to the vaccine might be? I think you touched on that.
Yeah, this patient predicted exactly what I showed, but well, what I showed was with myeloma, so we can't say that it exactly will be the same, but that's what I predict. I predict that even with a negative antibody response, first off, that does not mean there's no antibodies. So I'll share with you some of our preliminary data that even with this widely available commercial assay I showed you the data for, even when that says 0, when we do more sensitive testing in the lab, we can still find antibodies against COVID. And also, as I mentioned, this Mount Sinai study found CD4 T cells that were active against COVID, even when they did not have any antibodies. So I suspect there will be T cells. What I'm curious about are which types of T cells and how many, and how they may work against different strains. So that all I don't know, but I am fairly confident there will be some T cell activity and there is some partial activity, even when we don't see antibody responses.
Thank you. That's going to be comforting to a lot of people. If I test positive for COVID-19, what medications should I get to increase my chances of survival?
Yeah, that's a tough question because I think it's going to depend on the specific situation. So whether or not you're going to be admitted to the hospital, that's going to make a big difference. If you have access to the Regeneron monoclonal antibodies, I think that's always a good idea. They have emergency use authorization, and generally each institution or country has different pathways to get access to that. But with Waldenstroms, this is considered an immunosuppressed state. And if you get a positive test, for instance, at our hospital, at Massachusetts General Hospital, we would try to get you the Regeneron monoclonal antibodies. If you're home and trying to see if this is going to be a mild or a severe infection, you want to make sure you have a pulse oximeter to know your oxygen level, because you want to, if you do get worse, you want to be able to go right to a hospital.
Thank you, Dr. Branagan. The next question says, I read recently that Regeneron antibody therapy is being suggested for pre-exposure prophylaxis to prevent or minimize COVID-19 infection in those at risk of severe complications. Do you favor this expanded use for immunocompromised patients?
Yeah, we'll look at that lead-in. I just mentioned the Regeneron antibodies. So these are right now, as I mentioned, available for different scenarios. Yes, I believe that they work very well. So I am in favor of all of these different studies. So generally, that's sometimes the best way to get access to them is to be on one of these studies. So, for instance, there's studies looking at if you have a household member or close contact and you're immunosuppressed, will this help to get that to prevent you from getting COVID-19? So I think there's many questions, and if you're able to get them, I think it's a good idea because they seem to work fairly well.
Thank you. You recommend 2 doses of the Fluzone high dose for Waldenstroms patients. Does it require a doctor's prescription to get 2 doses?
Yeah, wow, what a great question. And it's a tough one because this is a new recommendation that's just come out. So it's not yet been adopted by the other bodies like the ACIP or the NCCN. And so insurance companies could, in theory, have a problem with that. Our institution has made a decision that wouldn't stop us from giving it, and if we would eat the cost if there was a problem with insurance. But there is a chance that your doctor's office wouldn't want to do that. So I would say, you could share this data with your doctor if there's any concern. What people do is, get one at a pharmacy and get one in the doctor's office. That's maybe not as ethical, but I haven't seen anybody have any trouble get 2. And before we made this approval at our institution, for the last 2 years, we've been advising, and our patients have been getting 2 doses. And I also haven't seen any troubles with insurance because, a flu vaccine is actually extremely cheap compared to what an insurance company pays out. So even though that's a theoretical concern, I haven't seen that materialize as a concern. So it's a great question. It's hard for me to say, you can get it no problem at your doctor's office. I wish it were. You can always ask your doctor to get a hold of me. I'd be happy to talk to them. And as I alluded to before, I really think we're going to come together at the next Waldenstroms workshop and have a consensus statement that will help make this a little more transparent so patients can get access to the 2 doses.
Thank you. What is the best timing of any vaccination in regards to Waldenstroms treatment?
This is a very important point and very understudied. So there are certainly some effects. For instance, auto transplant, when you get high doses of cytotoxic chemo, we know that wipes out the response to vaccines. And in fact, that's why you have to be revaccinated with all of your lifelong vaccines at certain time periods from that. So you want to, if you're on an alkylator chemo, it's nice to get as far from that dose as possible based on how often you're getting it. With other drugs, it's a little more challenging. So with monoclonal antibodies, for instance, Rituxan goes right to your bone marrow and it stays there for months. And we see effects that go well over a year. So at least in the data that I shared with you, even up to 6 months, there seemed to be some detriment to vaccine response. So this has to be balanced because when you have a flu season, for instance, if you wait till the whole flu season's over, you've missed your chance for a vaccine. So it's a very tricky question, and it's a very individualized on which therapy we're talking about. So I would say it's best to talk to your specific doctor about what treatment you're on and how to best time a vaccination.
Okay, thank you. Should Waldenstroms patients consider getting revaccinated with any recommended vaccines after treatment or when Waldenstroms is under control?
Yeah, I wondered the same thing, and it's almost as if this patient writing the question watched my video in advance because this is what it suggests, that when you have active disease and are progressing or are on certain therapies, you don't respond as well. So then this is what I wonder, but I think we don't know until we study that. So I think I would love to see some more data with our patients who try this on or off therapies. And we're doing this a little bit in our study, but it's just too early to say how well this works. But theoretically, that's a possibility.
Thank you. Do you recommend that Waldenstroms patients repeat the Pneumovax vaccination every 5 years?
Yeah, another great question. These are such contentious, difficult questions here, because the Pneumovax guidelines are very confusing, and so it's actually very difficult to answer this. Because Waldenstroms, again, is a disease associated with immunosuppression, the CDC has clear guidance that you can have a Pneumovax every 5 years. However, when you hit the age of 65, that recommendation then just becomes you get one and you're done. So it doesn't make a lot of sense, because if you're immunosuppressed before 65, for sure you're still immunosuppressed after 65, but that is how the guidance is in the US. There is some vague European Myeloma Network guidance that perhaps there's a suggestion you should think about this every 5 years. In the International Myeloma Working Group, there is a suggestion that if you're somebody with really severe immunocompromised state, perhaps you just keep going every 5 years. So this, I think, would be a great study. I would be great if somebody were to actually look at this so we know for sure. But I can't say, one way or the other, whether you'd be able to get that after the age of 65 every 5 years. But there is some suggestion that it would be beneficial.
Thank you. If I get the flu, should I take an antiviral medication?
Yeah, great question. I think the answer is basically yes. So if I'm assuming this is a Waldenstroms patient. I'm not saying everybody should go out and take it, but again, in general with Waldenstroms, you have some degree of immunosuppression. Perhaps if you were asymptomatic Waldenstroms and the symptoms were very mild, you don't necessarily have to. But as a rule, I would say it's safer to take it than to wait and let the flu infection perhaps get severe.
Okay, thank you. Is there an efficacy advantage to the Shingrix vaccine over long-term shingles prophylaxis with acyclovir or valacyclovir?
Yeah, another great question. So unfortunately, this has not been studied head-to-head for patients with Waldenstroms. So it's something we all worry or wonder. I don't say worry, but usually we think of it as the reverse, where the best treatment is the prophylaxis. And is the Shingrix going to be effective enough that you don't need that prophylaxis? And most of us are not comfortable with assuming that, especially because, as you've seen from some of the data I showed you, that responses to vaccine aren't as robust as healthy individuals without Waldenstroms. So there's a chance that you're not going to get the same protection as somebody without Waldenstroms, and you could end up with a severe zoster infection. So unless this is clearly shown, I don't think it's safe to not take your acyclovir prophylaxis when you are clearly in need.
Okay. You just answered the next question, so I'm going to skip to the following one. The Shingrix vaccine was recently approved for immunocompromised adults of any age. Do we know if protection wanes over time and whether a booster shot may be eventually suggested, particularly for the immunocompromised?
Yeah, again, wow, great question. We don't know. Data that led to the approval suggests that you don't need additional shots for healthy adults. But again, we know that the immune system is different for patients with Waldenstroms. So I would love to see someone study Shingrix specifically for Waldenstroms and look at this and other questions.
Thank you. This person says, is toenail fungus among the fungi to be wary of? I have it and can't get rid of it. What should I do?
Yeah, I'd say no. It's not nearly as worrisome as an invasive fungal infection, say, that can go to the lungs or the brain. It's mostly just that, it doesn't look pretty. And so, in general, you try first the topical creams, but if they don't work, there's systemic treatments, but those have some side effects. They're cleared through the liver, especially, and can interact with other medications. So, you have to speak to your doctor about if you'd be a candidate for that. But if you are, that usually gets rid of the toenail infection.
Thank you.
Or you just wear socks all the time. You don't
Right.
even look at your toenails.
Of course, that's an option. Are you aware of any vaccine research for the prevention of norovirus? I'm thinking particularly for those who travel on cruise ships or in other cases where outbreaks are likely to occur.
Yeah, no, unfortunately, I'm not aware of anyone doing research on that virus, but I would say we're still in the middle of a pandemic, and I would really caution, if you have Waldenstroms, do not take any cruises right now. Those are very crowded, risky situations.
I agree. Next question is, if I'm neutropenic, do I need to follow a special diet?
So that's a good question. Generally, if it's mildly neutropenic, no. But if this was really at the extreme, your doctor may worry about certain things like sushi, and also just in general eating out at a restaurant, which would be risky to where you don't know about the preparation of the food and things like that. So in general, no, but if you're severely neutropenic, then probably you want to talk to your doctor about that.
Okay, this is the last question. I understand that infections are a leading cause of illness and death for patients with all types of plasma cell disorders. We're often told that we'll die of something else besides Waldenstroms. When a Waldenstroms patient dies of an infection, for example, that is sepsis, shouldn't the cause of death be listed as infection secondary to Waldenstroms?
Yeah, what an interesting question, and I wish the person was here to kind of give the motivations behind that, because maybe it's because they feel that infections aren't tracked well enough, and I agree with that, because when we try to figure this out, how many people are dying of infection, it's very hard to figure out. So yes, I agree. I would love it if we could have more consistent causes of death. They're actually sort of all over the place with a death certificate. It's really the physician who's writing it puts whatever they feel is their best judgment. And so often that would be missed if it was a really serious infection and someone had Waldenstroms. And so that's not really getting into databases. So I think I understand the spirit behind the question, and I don't know a way to fix that, but I do agree with you that I wish that there was a way to do that.
Okay. Well, thanks again to Dr. Branagan for sharing his time with us to bring us such important messaging about preventing infections and for answering our questions. The IWMF is grateful to all of you in the audience for being with us, and I hope you enjoyed today's educational program. On behalf of the IWMF, I'd like to recognize and thank our sponsors: BeiGene, Pharmacyclics and Janssen, Selector Biosciences, the Treadway Foundation, and X4 Pharmaceuticals. Thanks, everyone, and have a great day.
And thank you very much. It was really a pleasure to join you today.
Thank you, Dr. Branagan.